All right, welcome everybody, and thanks for joining. We're going to give everyone just another minute or so before we get started. All right, so we are a couple of minutes after the top of the hour. We'll go ahead and get started. So welcome everyone again to this webinar on the ACO Primary Care Flex Model. My name is John Dickey. I'm the Chief Operating Officer with Eligibility Health Solutions, and I'll be your host today as we go through an overview of the new model recently announced by CMS, help to hopefully digest and provide some insights into the information that CMS has provided so far, and then offer a little guidance to organizations who are considering applying or participating in this model. A couple of housekeeping items to start. We will take questions as we go through the presentation. Y'all will see a little Q&A box, hopefully, on your screen, so feel free to type any questions as they come up. We'll try and get to some of those live, but in the event we don't, we'll have a Q&A session at the end where we'll get through or get to those questions. And then we will be recording, or we are recording, this webinar. So anyone who's registered will get a follow-up email with a link to this recording. So anyone who wasn't able to make it, or anyone who loved it so much they want to watch it again, will have that opportunity. So before we jump in, a little bit of background on us, just to provide some context and sort of the approach and where we're coming from here. So myself and many other folks on the Eligibility Health team have been working for a very long time in the value-based care space, going back, I guess now it's almost 12 years since the Medicare ACO model was created, and working to stand up and manage and support a number of ACOs over the last decade plus, including a lot of the newer models as they've come out. The most recent one is Reach and now Flex. Eligibility, we support customers really across the United States, all 50 states who are participating in value-based contracts. We provide analytics and care coordination technology services that support those organizations in driving better outcomes for the patients that they manage. Many of those in these Medicare ACO models. Successes so far, we judge our own success by the success of our customers, by our partners, and it's been a pretty good run. Looking at both the MSSP and ACO Reach, formerly known as direct contracting models, ACOs that we partner with do significantly better in generating shared savings, the numbers that really matter, than the rest of them that are out there. So we know that us partnering with these organizations drives success, and we're going to continue to do so under any new model that comes out like Flex. So let's talk about ACO Primary Care Flex. So start with an overview of this model. So ACO Primary Care Flex, or ACO PC Flex, or I'm going to call it Flex, is a new model announced by CMS just within the last several weeks. It's a new payment model. It's going to be 5 years, and it's being tested inside the MSSP ACO model. So this is a payment model inside another model. And what CMS is doing here is they're seeing whether or not increasing the amount of funding or reimbursement for primary care and changing the way that it's paid for, essentially moving away from fee-for-service and towards recurring monthly capitated payments will not only drive participation in the MSSP model, but also improve patient outcomes and reduce costs. So again, this model was just announced. It is going to start January 1st of next year. And for this test, CMS is limiting participation to 130 ACOs, which is actually quite a lot. It's about 480 MSSP ACOs active in the model now. So they'll let quite a few groups into this model, which is exciting. So the Flex model, we're going to call it a payment model. So most of the impacts are going to be on the payment side. And so participants, ACO participants in this model are going to receive prospective primary care payments, PPCPs. CMS loves long acronyms. So these are monthly prospective payments that are meant to cover primary care services delivered to ACO patients by ACO participants. And they're also going to get a one-time advance on shared savings. So those are the two kind of core pieces of this model. These payments are going to include a number of adjustments, but one of them is going to be one that drives participation for organizations who care for underserved populations. So things like federally qualified health centers and rural health clinics who historically haven't had significant participation in the MSSP model. CMS hopes to incentivize those groups to participate. So a little bit more about the components of this model. So I mentioned the advance on shared savings. So all Flex ACOs that are starting 1/1/2025 are going to receive a one-time $250,000 payment from CMS. It's an advance on their shared savings, and they get it one time. ACOs or have the ability to use this upfront payment to fund startup costs for the ACO and cover administrative costs for just sort of model requirements. So it does cost money to start up and run ACOs, and CMS is hoping this advance payment will help reduce some barriers to entry for groups who have not historically participated. It's not free money, so it must be paid back out of shared savings. So they're going to recoup that. And the $250,000 amount, it's the same for any ACO. So every Flex ACO is going to receive the same amount, whether they have 5,000 patients assigned or 50,000 patients assigned. The next piece that we talked about are these PPCPs, these prospective primary care payments. So these are capitated payments that are meant to replace fee-for-service reimbursement for primary care. So under the MSSP model that I think everyone on here is familiar with, participant providers who treat ACO beneficiaries submit claims to CMS and are reimbursed under the traditional fee-for-service model. This will change that. So ACO participants will no longer be reimbursed fee-for-service for primary care, and instead there'll be a monthly capitated payment that CMS pays to ACOs who are then responsible for reimbursing the participant providers in that ACO. And this is going to be a recurring monthly payment, very, very stable, especially compared to sort of the ups and downs that we see from fee-for-service. In CMS's words, looking at the data, this monthly capitated payment is going to increase primary care funding for most participants. The key word there is most, but that's a good thing that they've designed this model in a way that should lift reimbursement for primary care. Unlike the $250,000 shared savings advance, this monthly capitated payment is going to be specific to the ACOs. And there's four components that make up that monthly payment. We'll spend some more time on that in the next slide. The last piece here I want to talk about in the overview is quality reporting. So the good news here is not a lot changes. There's not a lot of new stuff when it comes to quality for the Flex model. So first of all, we talked about Flex as a model nested inside of MSSP. And so any Flex ACO will have the exact same quality measures, same quality reporting requirements as other MSSPs do. So that doesn't change. But CMS does add a one measure for Flex ACOs called the Person-Centered Primary Care Measure Survey, or PCPCM. So this is a survey. It's going to be patient reported. It's going to ask patients about their experience with primary care, really helping CMS assess, is this model having an impact on patients and their experience with primary care. The good news here, and this is not something that's been universal, so we're pretty happy to see this from CMS, is that CMS is going to pay for this. They're not going to require the Flex ACOs to cover the cost of administering this survey. CMS will cover the cost. They'll likely bring in a survey vendor. They're not going to be reaching out to patients on their own, but they're going to manage the administration of that survey. The other benefit of this survey, this additional quality measure, is that it's not going to impact shared savings or shared losses calculations for Flex ACOs. So all of that's going to mirror the traditional MSSP shared savings and losses methodology. We don't know exactly what this survey is going to impact, if it's just information for CMS or it's going to drive potential changes down the line, but at least for now we know that it's not going to impact savings or losses. So let's talk more about that primary care payment, that prospective primary care payment. So I mentioned before there's 4 components to that, and they get kind of complicated. We tried to do a good job of sort of condensing things down on a single slide. These are numbered 1 through 4, and CMS will figure these out in order. So the first piece of the monthly prospective payment is called the county base rate. And so what CMS is going to do is look at every single county in the United States and look at historical data to determine what the average Medicare spend is on primary care services for Medicare beneficiaries in that county. The universe is going to be any Medicare beneficiary who is ACO eligible. So they might be assigned to an ACO, they might not, but anyone who would be eligible for assignment to an ACO would be included in this analysis. So every single county is going to get their own county base rate. There will be one base rate for patients with ESRD and one base rate for everybody else, much like there's different benchmarks in MSSP for ESRD and for non-ESRD patients. So the county base rates are going to be the exact same for every single Flex ACO. CMS is going to publish annually a rate book that we understand will be similar to the rate book that's published for ACO REACH, for those that are familiar with that model. And so that'll be public data, and CMS is going to be publishing that ahead of each performance year. So that county base rate is sort of where things start. From there, there's a lot of changes. So the second piece is enhancements. So that county base rate is going to be enhanced in a couple of ways. And this is where CMS comes in and says, hey, we're going to enhance or increase the funding for primary care. And so the first is something called a county enhancement. So at the county level, and again, this would apply to each county and then any ACO who has beneficiaries living in any of those counties, they're going to identify counties who have historically lower primary care spend than national average levels. And so CMS is essentially going to take those historical averages and lift them. The idea here is that CMS does not want to entrench any historical patterns of low primary care spend or low primary care utilization in any of these counties. So they want to increase that payment for any of those, call it historically underserved from a primary care perspective, counties. So any Flex ACO who's got patients living in a county that has historical primary care spend lower than national levels will get a bit of a raise. So that's nice. The second enhancement is called the Flex enhancement. This is applied at the ACO level, and regardless of what counties ACO patients live in or what sort of historical utilization patterns have existed in those counties, every ACO is going to get a bump on those rates. So between the county enhancements, which will affect anyone with patients in a county with low primary care spend, and then all ACOs are going to get a lift through that flex enhancement. The nice thing about these enhanced payments is that it's not recouped by CMS. Again, back to talking about the ACO REACH model. Anyone who's familiar with that, there are enhanced payments that are available to REACH ACOs, which are nice, but CMS takes them back. So they're recoupable each year. These are not necessarily free money, but it's not something that the ACOs have to worry about paying back each year. After the county base rate and after the enhancements are determined, CMS is going to make adjustments to these monthly payment rates. And so these adjustments are going to include risk adjustments, so think clinical and social risk. So clinical risk, these are things like HCC coding, so clinical complexity of patients. So patients with higher risk scores or higher HCC scores are more complex and are going to result in lifts, positive adjustments to these county rates. CMS is also going to make adjustments for social risks. We don't know exactly the methodology here, but if we look at other models where CMS has made these adjustments, they're likely going to look at things like area deprivation index, proportion of patients who are dual eligible, so Medicare, Medicaid, and for populations who have higher levels of social risk, we would expect positive adjustments there. Another adjustment they're going to make is for care received outside of the ACO. So when CMS sets these county rates, they're looking at the average spend on primary care. Well, not every patient gets all their primary care from a single provider or a single practice. And so when CMS pays these capitated amounts out to the ACOs, they don't also want to pay fee-for-service to other non-Flex ACO providers who happen to be treating Flex ACO patients. But CMS doesn't want to double pay anything. And so there will be some kind of adjustment that CMS makes to offset the fact that not 100% of primary care is delivered by the Flex ACOs. Don't know what this is going to look like. They've had this sort of leakage component in other models, and sometimes it's been poorly designed. Sometimes it's been a little bit better designed. Like in the primary care first model, leakage was determined retroactively, and so primary care first practices were essentially dinged a year and a half into the model to offset these like overpayments that CMS had made, and it was like bad surprises. CMS improved on that model a little bit with Making Care Primary, or at least in the design of Making Care Primary, where they sort of baked in that leakage component into the upfront capitation rate. Probably going to be something that looks more like that here, but that will be an adjustment that'll be made, and we'll keep a close eye on that once the RFA is released. The other adjustment that CMS will make at this stage is at the patient level for any patients who are receiving the plurality of care, so more care than any other provider from FQHCs and RHCs. So these organizations are paid differently than other practices that deliver primary care. And so CMS is going to make adjustments for them, again, making it more attractive for them to participate in this model. So for the county base rate and the enhancements, yes, ACOs will see differences in the rates there, but where we would expect to see a pretty wide variation in what ultimately becomes the capitation payment is in this adjustment. It should be a fairly wide spread between different ACOs for all the adjustment reasons we just discussed. The last and probably least step or component in the prospective payment is this primary care prospective administrative trend, another long acronym. But after CMS makes these adjustments, they're going to take those rates and trim them forward to the performance year to account for any expected changes in spend or utilization sort of broadly across all of Medicare. These sort of trends are not new. They apply these in other models, but a lot of these trends in other models are retrospective. This one's going to be prospective. So that means this trend is going to be set at the beginning. So ACOs and participant practices should have a sense of what that trend impact is going to be on payments, as opposed to other models that apply retrospective trends. So we don't know what that trend adjustment is going to be up or down until the end of the year. And so that can result in some surprises, which are never great. So these are the four components. This is an area that people tend to have a lot of questions on. So do we. This is an area where CMS should provide a lot more detail in the RFA, which is scheduled to be released sometime this quarter. All right, so we talked some about the way the payments are set, model eligibility. So who gets to play in the Flex sandbox? First piece of eligibility, new or existing MSSP ACOs. So this is specific to MSSP. If you're a REACH ACO or if you're a participant in a REACH ACO, Flex is not for you. But if you're in Medicare Shared Savings Program ACO across any track, any of the basic tracks or enhanced, you have the ability to apply to participate. So that includes new ACOs, so folks who are hopefully working on their applications now to start in 2025, any ACOs who have gotten to the end of their agreement period and are renewing, or current ACOs that happen to be in the middle of an agreement period that want to participate. For them, they would need to reapply and start a new agreement period. But CMS didn't just make this available for new or existing ACOs, which is nice. The next piece, for any new or existing MSSP ACO, the Flex model is only available for low revenue ACOs. This is the eligibility piece that, call it the unfair one. So all MSSP ACOs are designated by CMS as either high revenue or low revenue. There's a calculation for that, but it's really based on the amount of Medicare revenue for the participants in an ACO compared to Medicare's entire spend for those ACO patients. But only low revenue ACOs are eligible for this model. What that means in practice, low revenue ACOs are physician-led, independent, essentially not led or anchored by large hospitals or large health systems. There's some exceptions to that, but we see some low revenue ACOs that might have a small hospital in it, but that's generally the way it plays out. So this little eligibility criteria here basically knocks almost half of the existing MSSP base of ACOs out. So a little bit fewer than half of MSSP ACOs are high revenue. Again, this is an area where a lot of folks are kind of raising their hands saying, hey, this doesn't make any sense. If we're under investing in primary care in general, it doesn't matter whether a hospital is part of an ACO or not. Medicare reimburses primary care the same. But anybody who is an MSSP ACO now, you'll know whether or not you're low or high revenue. CMS lets you know. Anyone who is a new applicant to start in 2025, CMS will let you know whether or not you're low or high revenue before the model starts. Next on the list is prospective assignment. So MSSP ACOs in the model get to elect prospective assignment or preliminary prospective assignment with retrospective reconciliation. Prospective or retrospective. Retrospective reconciliation all has to do with the way patients are assigned to the ACO. Under retrospective, ACOs, about 2/3 of MSSP ACOs are retrospective. The patient assignment or attribution list, who's aligned to the ACO, isn't finalized until the end of the performance year. And CMS uses all of the claims data for the visits that occur, for the encounters that occur during that performance year to determine, among other things, plurality of care. Prospective assignment means at the beginning of the year, prospective ACOs are told by CMS, here are your patients, and it's based on things that happened over the last 12 months. For this model, only prospective assignment is allowed. And this really has to do with the way those prospective payments are coming. CMS is making these upfront capitation payments on a monthly basis, and it only makes sense to do that if they know who those patients are that are aligned, as opposed to sort of waiting throughout the year to have that determined. Last piece on the eligibility side has to do with overlap. Virtually all CMS models and innovation models have some sort of overlap restrictions, and Flex is no different. The first two on the list, ACO reach, well, you can't be an MSSP and reach at the same time, so that's not new. Same with making care primary, so this new model that's about to kick off, practices cannot participate in making care primary or MSSP, so no real difference on when you include Flex. The last two on the list are unique to Flex. So primary care first, which is a model that started in 2021 and is still going. Under MSSP, practices who are part of MSSP can also be part of primary care first, not the case for Flex. So something to be aware of, and we'll talk a little bit more about it later. And then Flex ACOs can also not receive AIP, Advanced Investment Payment, which is the new-ish model under MSSP. And really, that's just because CMS isn't going to double pay. That upfront $250,000 is very similar to the way those AIP payments work. And so an MSSP ACO can't receive AIP payments and be a part of Flex. So why now? Why is CMS rolling out this new payment model? You can go read their website, and they have very, very lofty goals and reasons they're doing this. But first and foremost, MSSP participation has really plateaued over the last few years. And CMS has had trouble incentivizing participation of new ACOs and new providers joining ACOs that hadn't historically participated. CMS also has a very lofty goal of having 100% of Medicare beneficiaries in some kind of accountable care relationship by the end of this decade, which is fast approaching. And so they see this as an opportunity to incentivize that participation. In our opinion, it's a really good way to incentivize it. CMS also really wants to, and they've been doing this, we're trying this for a while, to incentivize ACO adoption from FQHCs and RHCs. This is twofold. One, it's a group that historically has not had a lot of participation in ACOs. And because these organizations tend to serve patients who are historically underserved, this has the impact of ideally improving health equity as well, which is a big goal of CMS's. So why low revenue ACOs? We talked some about this, being kind of unfair. But low revenues historically have performed better. They've generated more shared savings than high revenue ACOs. So CMS wants more of those. And CMS feels that low revenue ACOs who might not have backing from large organizations like health systems would see Flex and the upfront payments and stable monthly payments as a way to reduce financial barriers to entry and incentivize groups who might otherwise not participate. The last piece is pressure, lobbying from the industry. So there's been a lot of push CMS has gotten from groups wanting more models with prospective payments. A lot of people really liked the monthly capitation payments that Primary Care First has, that Making Care Primary will have, that Reach ACOs have. And in general, I guess probably forever, CMS has been poked about underpaying primary care. So they kind of kill two birds with one stone with this model, which is great. So next couple of slides, what are the pros of participation? So what's in it for me? And then what are the cons, or at least things that folks want to consider about participation? So on the benefit side, The shared savings advance is great. So starting up an ACO costs money. There are costs to starting up the ACO, just general administrative costs to running it. And so having this $250,000 chunk of change up front can really help offset some of that and allow organizations who wouldn't have had the funding to come in the model. And that can be used to, again, offset the cost of starting the ACO and also just ongoing administrative costs for the ACO. For MSSP, the first payment, or the time between the first performance year and if you generate shared savings, getting your first check is a long time, like September, October of the following year. So this, again, advances some of that up front, which is nice. The next piece has to do with the way your ACO providers are compensated. This move away from fee-for-service to this steady, stable, monthly recurring cash flow is great. What we saw back when COVID happened, and then more recently with the Change Healthcare cyber attack, the fee-for-service model is fragile. And so moving away from submitting a claim, getting paid, to recurring payments is very attractive for ACO participants and even ACOs, as those capitation payments are going to run through them. The enhanced capitation payments, we talked about this, they're not recouped. It's not quite free money. There's some strings attached and some rules around how you spend it. But the fact that this is not recouped means the ACOs and the providers can invest these dollars in advancing primary care and improving primary care without necessarily being concerned about generating short-term returns. So again, the example with the enhanced capitation payments for ACO REACH, CMS recoups those every single year. So every one of those dollars needs to be invested and create a return because CMS is going to take it back at the end of the year. In this case, they won't, which is nice. So worry about long-term investments in improving primary care. The last piece here, just a general increase in primary care reimbursement. Again, based on the numbers that CMS has run, most ACO participants are going to see their reimbursement for the funding for primary care increased. And I think everyone agrees that's sorely needed. Another benefit that's not on the screen has to do with recruiting. So the MSSP model has been around over a decade, and anyone who is currently, is an ACO or is even just a primary care practice knows that the annual recruiting of participants to an ACO is an interesting endeavor. Providers are constantly jumping ACO to ACO, and it's a constant game of recruiting. So any ACO who's a participant in Flex now is able to offer a different and probably very beneficial payment model to their ACO participants. So which could be a leg up as you look to recruit high quality providers into your ACO. What about the cons? What should we be worried about, or at least aware of, so that you can plan for? So when we talk about costs to the model, these aren't necessarily hard costs, but just excuse me, things that need to be prepared for. So the first are restrictions on how you spend these dollars. That $250,000 advance, you got to pay it back. It's not free money. Best way to think about that is an interest-free loan. So you get that money, you can use it as working capital, but CMS is going to take it back, and there will be some limitations on how you can spend it. For the enhanced payments, so the enhanced portion of those monthly capitation payments, CMS is going to have restrictions on how that can be spent. So we don't have all the detail yet. It'll come out in the RFA, but CMS will establish these spend categories and will set some minimum levels or proportions of spend to make sure that those dollars are going to what CMS feels are the right areas. So you can't just take that money and bonus all the ACO executives. The second piece is paying providers. So MSSP ACOs today cut checks to providers maybe once a year. It's shared savings disbursements. So not so bad when you have to do it once a year, but Flex ACOs are now responsible for compensating their primary care participants for all primary care. So these are going to likely be monthly payments that are going to need to be made to these providers. So the ACO is not only going to have to figure out, how do I cut checks every single month to all of my practices, which again just operationally needs to be considered, but also how am I going to pay my providers? Already, you've got to figure out your shared savings distribution methodology and how you determine which participants have earned how much of savings. But now you've got to do things like, well, how do I want to pay them? CMS is incentivizing, or they're encouraging Flex ACOs to pay things like capitation to their providers. So how do you set that cap rate? How do you manage the fact that some of your ACO patients might see different providers or practices inside the ACO? So how do you assign or allocate dollars between a couple of different groups? So again, certainly not insurmountable, but just something that needs to be considered as you plan for the model. The next is reporting requirements. I love every time CMS comes out with a new model, they always talk about things. They want to reduce the administrative burden on ACOs or providers, but then they always add new requirements. So for this one, it's no different. CMS is going to require, in their words, detailed annual spending plans. So how you're going to invest these incremental dollars in improving primary care. We don't know exactly what those are going to look like. We'll, again, with a lot of this, you'll learn more in the RFA, but that is going to be something that someone's going to have to not only come up with, but put together, document, ship off to CMS and potentially answer questions on. In addition to the detailed annual spending plan, CMS has said that they're going to require quarterly spend reports, short form reports. So these should be less intense and less detailed than the annual plans, but each quarter CMS is going to want to know how you're spending those dollars. For the survey measure that is introduced for Flex, CMS is going to pay for it. They're going to administer it, but they have indicated that they might ask for some information from the Flex ACOs, things like roster data, phone numbers for your patients, for example. That would just allow them to actually administer the data. So to the extent the ACOs have that, it will be pretty easy. If not, I'm going to have to go to your providers and get that information. So that'll be likely just an annual request from CMS. It looks like there's going to be some sort of health equity reporting requirement on this. Health equity has become baked into all of these new models from CMS. And so there will be likely some kind of reporting that is required there. And again, like the roster data might require the ACOs to go to their participant providers to collect some additional information on assigned patients. And then the last one here that we know of, just like any of these new models, CMS is going to want to talk to you. They want to see how things are going. They want to ask you about what you're doing and how. And so again, it'll just take some time from folks in the ACO to have those conversations. So none of this seems super onerous, but again, it will be incremental to what's required under just the MSSP model. Last sort of concern here are, call it limitations on some flexibility that you would have as an MSSP ACO. So there are lots of different options that around participation that ACOs get to make, and you just have a little bit fewer under the Flex model. So we talked about prospective assignment versus retrospective. You have to pick prospective. Again, about 2/3 of MSSP ACOs out there selected retrospective. And so that is something that you'll need to consider as you contemplate applying to the Flex model. The fact that only low revenue ACOs are eligible for this model means you're likely going to exclude participants who are hospitals or health systems. That might not be an issue for you because you're a physician-led independent ACO, but as you put your ACO together, just know that if Flex is important, then you need to be careful about what participants you let in. The last one is excluding primary care first practices. So there are a little over 2,000 primary care first practices. That's like at the physical location level, so fewer tens than that are in the model. But anyone that's in primary care first can't also participate in a Flex ACO. So for new entrant ACOs who are going to be starting in 2025, keep that in mind as you're recruiting practices to the ACO. Any existing ACO who is looking to join Flex in 2025, you need to take a look at your participants and see, is there anybody who's in primary care first today? Because I either have to boot them out of the ACO or have them leave the PCF model. All right, so next steps, where we go from here. In our opinion, and I think the opinion of lots of folks who have weighed in, Flex is really interesting. I think for a lot of ACOs out there, new and existing, it represents a very exciting opportunity, both in the stable monthly capitation payments and then just the general lift in funding for primary care. Despite some of the concerns or things to be aware of that we covered, I think in most cases the benefits far exceed the administrative or operational costs of participation. So strongly recommend that folks take a look at this model. And like CMS, we would also say, we Acclivity would strongly suggest that all new entrant MSSP ACOs apply to Flex. CMS is encouraging it, and we do too. But also any existing ACOs should really consider it as well. So the way that a new or existing ACO applies to the Flex model is first notating that in their MSSP application. There will be a little section in that application where you'll denote your interest. After that, there will be a separate Flex application that comes out. If you look at the timeline here, the bookends there are known dates. We know the MSSP application opens May 20th, closes June 17th, and the Flex model starts January 1st. It's kind of fuzzy in the middle. So CMS has said the Flex RFA and the application itself, they expect to release sometime in Q2 and have it due in early August. The issue is Q2 is 3 months long. And so we don't know, but there's a chance that the Flex RFA and application could come out after the MSSP application window closes. And so, or even if it comes out before it closes, it might not be enough time for organizations to really dig in to the Flex RFA and make an informed decision. So if there's any interest or possible interest in participating in Flex, we would recommend that the ACOs notate that in their MSSP application and go ahead and work through the Flex application. The applications are non-binding, and you can always withdraw them later if you change your mind. All right, those are my slides. I think you did a good job. I wanted to leave 15 minutes for Q&A, and we did. All right, and I know I told everybody I would try and answer some of these questions live, but I didn't, so we'll get to them now. All right. First question, how will CMS report leakage? Will it identify the patient that leaked and where the leaked service was provided? In primary care first, it's nearly impossible to figure out what was driving leakage. So the short answer to your question, Jeff, is I don't know. All CMS has said is that there will be adjustments to account for care delivered outside the ACO. If I had to guess, so I think CMS learned a lesson from primary care first. A lot of blowback from practices who were surprised when they got their first leakage adjustments and were unhappy with the amount of detail or lack thereof from CMS on leakage. That it probably looks something more like what they've laid out for making care primary, where They're going to look, historically and say, okay, well, about how much is leakage has occurred in the past, and then make an adjustment prospectively to those monthly payments. But as far as what detail will be provided, my guess is they're gonna point the Flex ACOs back to the CCLF files, the same thing they've done in primary care first, where they say, well, you've got all the claims data, so you can take a look at where your patients are getting care, which is not something that MSSP ACOs today aren't concerned about, right? If you've got a patient, you've got a primary care provider who's a participant in your ACO, and that patient's going somewhere else, you want to rein that patient back in. So it's probably not that different from the way a lot of ACOs operate today. Next question: are there specific adjustments for the prospective payments at FQHCs? Are they known? They are not known. So that detail will come out in the RFA, and we expect CMS to go into a fair amount of detail. Just FQHCs and rural health clinics are paid very differently from typical practices, and so that adjustment is going to have to account for that. Not only account for that, but also, again, per CMS, incentivize participation from those organizations. We do know that adjustment is going to be at the patient level, though. So we expect that there will be patient level detail about those adjustments. Next question. We got a lot of questions. Great. Do ACOs have to pay their providers through capitation? So no. What we know for sure is that the ACOs are going to have to pay their providers. So CMS is still going to require participant providers in Flex ACOs to submit claims to CMS for primary care services. CMS on their end is going to figure out, is this a primary care service for a Flex ACO patient? If it is, they'll zero it out. And it'll be a non-paid claim for that provider. So CMS will leave it up to the Flex ACOs to reimburse their participant providers for primary care services. We'll see what kind of restrictions CMS puts in place. But so far, they've said that they're going to encourage ACOs to move away from reimbursing their providers under fee-for-service. CMS moving away from fee-for-service and capping the ACOs doesn't necessarily have a big impact if all the ACOs do is map to the physician fee schedule to reimburse their Flex participants. So expect some encouragement. I don't know if it'll be strong-armed encouragement or not, but that's what we know so far. Next question: how will CMS determine whether a provider is a primary care provider, PCP, or specialist? So I think this goes back to talking about the focus of the model is changing the way primary care is reimbursed, and CMS setting these prospective capitation payments to replace primary care services. So, how does CMS going to know what's primary care and what's not? For physicians, that's generally pretty easy. There's a lot of different taxonomies out there. It gets tougher when you get into the non-physician practitioners, your nurse practitioners, your physician assistants. A lot fewer taxonomies. That's been an issue actually in primary care first, which we were talking about. So CMS has they brought that up, but they've pointed everyone to, hey, read the RFA. Information will come out there. So that is another area that we're going to take a close look at, because honestly, I think it's really tough in a lot of cases to determine if a nurse practitioner in a specialty practice is in a specialty practice just based off the what's submitted in a claim. A couple more questions. Will there be support services with this model? The CMS PCF payment adjustment, they didn't offer any assistance on decreasing this adjustment. Will they offer assistance with the Flex model? TBD. So there will be support, general ability to call in. They'll have a Flex team, phone or email. As far as will they provide guidance, I think is probably where that question was going on how an ACO can improve performance or mitigate any, call it negative adjustments to those cap payments. We'll see. I think there's obviously a push for that in these other models like primary care first. But CMS oftentimes is receptive or responsive to requests, to suggestions from organizations who participate in these models. Definitely not 100% of the time, but I think to the extent you have suggestions or concerns or questions between now and when the model starts, shipping those over to CMS at least gives them a sense that people are thinking about it. All right, and then the last question, will higher primary care reimbursement make it harder to make shared savings? It's a good question. So yeah, CMS is lifting the overall reimbursement for primary care. Does that increase ACO expenditures and make it harder to achieve shared savings? So the enhanced pieces we talked about aren't recouped by CMS, so they're not going to count those as claims expenditures for the ACO. So no there. But to the extent any of the county level adjustments or any other non-enhanced pieces of that capitation payment lift primary care reimbursement, it would lift total expenditures. But the good news is, I think anywhere like 2 to 3% of total Medicare spend goes to primary care. And I don't know that there's anyone out there that would argue that's too much, or that a good way to achieve savings in an ACO is to reduce primary care. Actually, the data out there has pretty clearly shown that the ACOs that are the most successful have much higher than average spend on primary care. So it's I think a really good place to invest. All right. Well, I think that that does it for the questions. I don't think there's any that I missed. Thank you everybody for joining. Anyone that has additional questions after the fact, or questions that I didn't answer to your satisfaction, feel free to reach out. So best way to reach us, info@acclivityhealth.com. You can go to our website, submit questions, but certainly any follow-up questions or any additional guidance we can help as you think about the flex model, whether or not it makes sense to participate, please reach out. Thanks everybody. Have a good day.